There are a couple tests you can do to check the integrity of the collateral ligaments for the elbow. These two tests would be the valgus stress test and the varus stress test. So if you wanted to check the UCL or the MCL, you would do the valgus stress test, and the patient will be supine with elbow flexion at about 20 degrees, and then you're going to stabilize the humerus and then provide that valgus force into the forearm. So you want to compare one side to the other, and you're looking for laxity and for any reproduction of the medial complaints of pain. So it's considered a positive test if there is laxity compared with the uninvolved side. So the other test is the varus stress test for the LCL. And similarly to the valgus stress test, you're going to be in a similar starting position. So your elbow is going to be about 20 degrees of flexion again and stabilize at the distal humerus. And then now you're going to provide a varus force through the forearm. And again, you're looking for reproduction of any radial-sided pain and or increased laxity compared to the uninvolved side, which would be considered a positive test. A test you can do if you suspect a problem at the UCL is the milking maneuver test. So the patient is seated with their arm up at 90 degrees of flexion with their forearm supinated so that their palm is up, and you're going to stabilize at the elbow. Then you're going to pull down onto the thumb to create a valgus force at the elbow. And it is considered a positive test if you reproduce the patient's pain. The moving valgus stress test is another test you can do to stress the UCL if you suspect a problem at the elbow. And what you're going to do is you're going to have the patient seated and bring their arm into about 90 degrees of abduction. And then you're going to put the patient into full elbow flexion. And then you're going to use your hand to provide some valgus stress right at the elbow. And then while you're giving that valgus stress, you're gradually straightening the elbow out. So if you reproduce the pain somewhere between 120 degrees to 70 degrees of elbow flexion, that would be considered a positive test. So you're really looking to see if you get that pain reproduced in that painful shear zone. So again, it's considered a positive test if the person complains of medial elbow pain. There are 3 tests you can do if you're suspecting lateral epicondylitis at the elbow. The 3 tests are the Cosen's test, the Mills test, and the Maudsley's test. And you can do these in the same order if you'd like. So if you want to start, you can start with the Cosen's test, which is the first test. You're going to have them make a fist and pull their wrist up into extension. And then you're just going to tell them, don't let me push you down. So you're doing resisted wrist extension, looking for reproduction of their complaints. So it's considered a positive test if it reproduces the lateral epicondyle pain. Next is the Mills test, where you're going to put the extensors on stretch, so you're going to straighten the elbow. And you're going to also flex at the wrist and fingers. So that passive stretch, you're looking for the reproduction of their complaints. And again, that's considered a positive test if it reproduces their lateral epicondyle pain. Lastly, you can do the Maudsley's test, which you're going to have their elbow relax, and you're going to do resisted middle finger extension. And you want to make sure you're distal to the PIP joint, so here you're really just providing that resistance there. That's just trying to, again, elicit any pain or discomfort right at the tendon for the lateral epicondyle. And so that would be considered a positive test. A test that you can do if you're suspecting a rupture of the biceps is the biceps squeeze test. So you're going to have the patient rest their hand on their thigh somewhere between about 60 to 80 degrees of elbow flexion. Then you're going to come out behind them and you want to get right at their biceps and you're going to squeeze there. And when you squeeze, you should see that there's a little bit of supination that happens at their forearm. And so if that was not intact, the biceps weren't intact, you really wouldn't see any motion occurring at the forearm, and that would be considered a positive test. So again, it's positive for a rupture if there's failure of the forearm to supinate. If you're suspecting an ulnar nerve entrapment or pathology around the cubital tunnel, a test that you can do is the elbow flexion test. So here you're just going to tell the patient that you want them to bring their arms and just rest their hands as far back as they can, and you're going to have the patient stay up there for about 3 minutes to see if they can reproduce any of their symptoms, their ulnar nerve tingling and paresthesia. And during that time, you can also have the patient come up into shoulder abduction as well, and to put a little bit of further sensitization on that. So it's a positive test if there's tingling or paresthesia in the ulnar distribution of the forearm or the hand. Another test you can do if you're suspecting nerve irritation of the ulnar nerve at the cubital tunnel is the Tinel sign. And with this test, you're going to have the patient relax their arm on you, and you're going to go right into that cubital tunnel and tap. So there you're going to tap over the cubital tunnel groove between the olecranon and the medial epicondyle 6 times. So you're looking for reproduction of their complaints. That would be considered a positive test, and you always compare to the uninvolved side. So again, it's positive if there's tingling in the ulnar nerve distribution. If you suspect a nerve involvement of the anterior interosseous nerve, or the AIN, you can do the pinch grip test or the teardrop test. So here you're going to basically tell the patient to make an OK sign. So you ask your patient to try to touch the tip of their thumb to the tip of their index finger together, like you're making a big round O. And if you see that the patient begin and kind of go more to their tip to a pad, then, and especially begin to lose what's happening at the IP joint of the thumb, that's considered a positive finding for a problem at the anterior interosseous nerve. One of the tests that you can do for suspected carpal instability, especially at the scaphoid, would be the Watson or scaphoid shift test. So here you want to bring the patient into max ulnar deviation and slight wrist extension, and you're going to take your thumb and go to find the scaphoid, and you're going to push on the scaphoid from the palmar surface, so pushing it dorsally. And while you give that pressure, you're going to bring the patient into radial deviation and slight flexion. And what will happen is oftentimes you'll get a thunk or a clunk, and if you move your thumb away as a scaphoid dislocates, that would be considered a positive finding. So the scaphoid will sublux if it's unstable when moved from the ulnar deviation to radial deviation with a dorsal glide applied via the thumb. When you're assessing for carpal instabilities, there are a couple areas that are potentially troublesome. This would include the scapholunate region and the lunotriquetral region. So you want to do shearing or ballottement test for those. So to do the scapholunate shear, you want to find the scaphoid and the lunate. So you first slide down into the third metacarpal until you drop right off to the capitate. Then from the capitate, you're going to move just slightly ulnarly and proximally, and you should land over the lunate. And the scaphoid, you can find that via the anatomical snuff box. So you're going to bring your thumb and you're going to go over the scaphoid here. So once you have the scaphoid and the lunate, now you're just going to shear between the two. And here you're feeling for any hypermobility compared to the other side, or a reproduction of the patient's complaints of pain. And from that, since you already found the lunate, you can go into doing the lunotriquetral shear. So here you're going to take your finger and keep it right over the lunate where you found it. And then you're also going to come over the pisiform, which is going to sit on top of the triquetrum. So once you do that, you're going to apply your shearing here, and that would be between the lunate and the triquetrum. And so again, you're just going to assess for hypermobility compared to the uninvolved side or the reproduction of complaints. So if you're suspecting carpal instability, another test you can do is the Lichtman midcarpal shift test. So this would be more of a midcarpal instability, so maybe instability between the proximal and the distal rows of the carpals. So for this test, the patient is going to sit with their arm resting in some pronation, and you want to palpate the capitate, and you're going to provide pressure on the dorsal aspect. You're going to have the patient start in radial deviation, And you're going to actually load through the carpals first, then move into ulnar deviation. This would be considered a positive test if you feel the proximal row sublux. It might jump towards you, and that would be considered a positive test for midcarpal instability. Another test you can do for suspected carpal instability is called the finger extension shuck test. And what you're going to do here is you're going to have the patient rest their hand in some wrist flexion, and their MCPs are also going to be in some flexion, and you're going to provide some resistance. So you tell them, go ahead, push into me. So they're doing resisted extension, just distal to the MCP joint. And this would be considered a positive test if it reproduced any of their complaints of pain. So this is the thumb CMC grind test. So first, if the patient's complaining of some radial-sided pain or pain at the base of the thumb, and you want to see what's happening at the CMC joint, you could try to first load the joint and see if you could reproduce their complaint of pain. So you just stabilize at the distal radius and carpal regions and take the metacarpals and load right down into the carpal metacarpal joint. And so that would be the load test. And if you wanted to make it a grind test, you would stay loaded, and then from there, you would do some circumduction in that area. So in either case, you would be looking for reproduction of their complaints of pain. With the grinding, you might also feel for any crepitus or crunching, and that would be considered a positive test. If you want to assess the joint integrity at the distal radial ulnar joint, there are two different tests that you can do. One is called the piano key test, and you're just going to have the patient rest their arm with their forearm in some pronation, and then all you're going to do is take your thumb and put it right over the distal ulna and just push down as if it were like a piano key. And so what that does, it creates shear between the distal radial ulnar joint. And it's a positive test if you reproduce their complaints, and you would also compare it to the uninvolved side. And for the distal radial ulnar joint stress or ballottement test, you're going to come in and go stabilize at the distal radius, and then you would hold on to the distal ulna and shear in an anterior and posterior direction. And it's a positive test if you reproduce the patient's complaints of pain right at the joint. So this is the UCL stress test for the thumb, and you can do this if you're suspecting that the patient has had an UCL injury to the thumb, or what some people call the gamekeeper's or the skier's thumb. So you do this UCL test where you're going to hold the CMC joint in about 30 degrees of flexion and stabilize there. And then with your other hand, you're going to provide a stress to the UCL and see if you can reproduce their pain or if there's excessive motion. So if there's more than 30 degrees of movement, then that would be indicative of at least a partial tear of the UCL, and you would compare to the uninvolved side. So again, it's a valgus stress at the MCP of the thumb to stress the UCL. If you're suspecting a lesion at the TFCC or the triangular fibrocartilage complex, you could do a shear test for that area. So here you're going to just take your finger and put it on the pisiform, which sits on top of the triquetrum, and then your thumb you would then put on the distal aspect of the ulna. And all you're going to do here is you're going to squeeze and create shear across the TFCC. So a positive finding would be reproduction of the ulnar-sided complaints of pain. If you want to assess for triangular fibrocartilage complex problems or TFCC problems, you can do the press sit to stand test, and all you need is a chair with armrests. And what you're going to do is you're going to have the patient rest their hands on the armrest, and then you're going to ask them to get right up and push against their armrest and push through their hands. So you can tell them they can use their legs just a little bit, but it's really mostly pushing with their hands to come up. So you're looking for reproduction of ulnar side complaints of pain, and that would be considered a positive test. This is the supination lift test, which is another test you can do to assess the TFCC. And so you just have the patient seated with both arms supinated out in front. And then you can either provide manual resistance, so you're going to go ahead and tell them to push up and bend their elbows up into you. You can do that, or you can also just have the patients take their hands and put them under the table and have them pull up like they're trying to lift the table. And all you're looking for here is the reproduction of owner's side complaints of pain. So it's considered a positive test if the pain is localized to the owner's side of the wrist as they try to apply that force. If you're suspecting that the TFCC is the potential source of hand complaints, then you can do two tests, the impaction test and the load test. So the impaction test, you're going to have the patient resting with their elbow flexed, and you're going to take them into ulnar deviation. And then you're going to axially load or create impact through the fourth and fifth metacarpals. And here you're looking for reproduction of complaints of pain, so looking for pain on the ulnar side of the wrist. And then from that position, you can go ahead and go into the load test, where here you're going to have the patient go into wrist flexion and extension while they're still in that ulnar deviation. And so you're providing the axial load again through the fourth and fifth metacarpals. So it's positive if you get a click or crepitus or pain. This is the Bunel-Littler test, and it's a test you can do to determine if a person's limitation in their PIP motion is due more to intrinsic muscle tightness versus the actual joint. So to do this test, you would keep the MCP joint in relative neutral, and you would then passively see how much motion the person has at their PIP joint. If they were limited, you wouldn't know if the limitation at the joint was due more to the joint being tight, the capsule, or if it was the intrinsic muscle tightness. But then you would put the MCP joint into some flexion, and then you reassess PIP joint motion. If the motion increased, then you would know now that the problem that you were seeing before was because of intrinsic muscle tightness of the hand. And versus if you put the MCP joint into flexion but you still have the same limitation, then that would mean that the joint itself at the PIP was tight and limited. This is the Haynes and Coley test, which is similar to the Bunel-Littler test, except now you're trying to determine if the person's limitation in their DIP motion is due more to intrinsic muscle tightness versus actual joint tightness. So to test the DIP joint, to try to determine again if it's the joint itself or if it's the oblique retinacular ligaments, then you're going to have the PIP joint in an extension, and then you passively see how much you have in motion at the DIP joint. So say the DIP joint is limited, and you don't know yet if it's coming from the joint itself or if it's coming from the retinacular ligaments. So then if you flex the PIP joint, and then you reassess the DIP flexion, and if the flexion increases in that position, then that would mean that the limitation you originally saw was due to the retinacular ligaments being tight. But if you had the same amount of joint motion in both positions, then that would mean that the joint capsule itself was tight. If you have any concern that the patient may have decurved veins or some inflammation or tenosynovitis of that first extensor compartment, then you can do this test, which is the Finkelstein test. So what you're going to do is you're going to have the patient cover up their thumb with their fingers, and then you're going to passively bring them into maximal ulnar deviation. And here, this would be considered a positive finding if you reproduce the pain right across the stuff box or in that compartment. When you're assessing a patient and you're trying to isolate out to figure if the problem is more the flexor digitorum superficialis or FDS versus the flexor digitorum profundus or FDP, there are two tests that you can do to help you isolate out and figure out which muscles are working. So if you want to first isolate out for FDS, you can have the patient rest with their hand out and arm out straight with their palm up. And then you can just tell them to just bend this one finger up while you actually hold on to the other fingers straight. And because you're holding the other finger straight, you can see that she's not using the profundus for this, and it's relaxed, so you know that the FDS is firing. So you can do this for any finger. So if you want them to do another finger, tell them to go ahead, bend, and you can go ahead and do the same. And so if you wanted to isolate out for FDP, so you're going to block everywhere else and go have them bend their finger at the DIP joint. And you can see there she's getting this active flexion at the DIP joint, so that tells you that the profundus is intact. This is a test you can do to test the integrity of the extensor hood, and you would do this if a patient has difficulty with straightening out their fingers, and so you're concerned about the integrity of the extensor hood mechanism. So you're going to have the patient resting with their PIP joint supported, with their 90 degrees of flexion, and then you're going to give very light resistance. So you're going to ask the patient to extend their finger out straight, or fingers. So you can either do all fingers or just the one. But it's considered a positive finding if, say, she really can't provide any pressure or have the ability to extend against my resistance. This is the Phalen's test, and you can do this if you're concerned that the patient has a carpal tunnel syndrome. So you would have the patient put their backs of their hands together and try to maximally bend out their wrists as far as possible. And you'd have the patient stay like this for up to 60 seconds. And you're looking for any reproduction of numbness and tingling or pain that they might feel in the median nerve distribution. So a positive test is if there's reproduction of symptoms at the median nerve within 45 to 60 seconds. This is the hand elevation test, and if your patient does have the shoulder range of motion, this is another test you can do if you're suspecting carpal tunnel syndrome. So you're going to have the patient elevate both their arms as high as possible and bend down at the wrist, and you would have the patient stay there for about 3 minutes, and you have to see if the patient reproduces their complaints of paresthesia or pain in the carpal tunnel or the median nerve distribution. So again, it's positive if there's reproduction of symptoms at the median nerve within 2 minutes. This is the carpal compression test, which is another test you can do to assess for a median nerve for possible carpal tunnel syndrome. So you'd have the patient resting with their forearms supinated, and then you're going to take both of your thumbs and use dummy thumbs and go right over where the median nerve would sit. And then you're going to be applying compression. So you want to apply compression for up to 30 seconds and see if you could reproduce their complaints of median nerve irritation or paresthesia. This is the reverse Phalen's test, and it's another test you can do if you're concerned about carpal tunnel syndrome. So what you're going to do is you're going to put the palms of your hands together and drop down so you're getting a max extension, and so it's like you're in this praying position, and you're going to hold that for up to 60 seconds. So it would be considered a positive test if you get reproduction of complaints of tingling or paresthesia or pain in that median nerve distribution. Another test to assess the median nerve at the carpal tunnel is the Tinel sign at the wrist. So it's similar to what we did at the cubital tunnel for the ulnar nerve. So you want to palpate and you want to do your rapid tap over the median nerve. It's considered a positive finding if it reproduces the paresthesia or tingling or anything like that distally. With this way, you're still going to have the patient with their palm up, forearm supinated, and you're still tapping right over where the median nerve is sitting. So you're doing light percussion along the nerve still. But you can start at the fingertip and then move proximally. So here you're starting at A on the fingertip, then B would be at the wrist, and then more proximally you go to C, and then D. So you're looking to see at any point if where you maybe get a response, and that sometimes corresponds to a level of axonal regrowth. So say a person had carpal tunnel surgery and you're trying to see how much of return they're getting in the median nerve post-op. This is the Froment sign, and you can do this test if you're suspecting that your patient has an ulnar nerve injury in the hand. So you just take a piece of paper and then you're going to have the patient hold on onto this with a pinch, and you tell them, don't let me pull this paper out from you. And you can see she does it well, so this is a normal test. But what would be abnormal is if she can't hold on unless she compensates by hyperextending at this point here and flexing at the IP joint, because the reason for this, if you see this, would be indicative of an ulnar nerve problem because the ulnar nerve is innervated by the adductor pollicis. So it would be a positive test if she has the inability to flex between the index finger and thumb without flexion at the IP. This is the Allen test, and you can do this test if you want to check the vascular integrity of the hand. So what you're going to do is you're going to first find the radial and ulnar arteries. Then you're going to tell the patient, okay patient, about 5 times, just open and close your hand. And on the last time, you're just going to keep your hand in that fist. Now I'm going to compress at both arteries. Now, patient, just let your arm relax, and I'm going to, one at a time, going to let the ulnar artery go. And I want to see it fill over on this side. And then we're going to repeat the test. So I want you, patient, to go ahead, open and close your hand again 5 times. And then I want you to relax your hand, and now I'm going to let go at the radial artery, and I should see filling on this side. You should see filling of the entire hand within 5 minutes, regardless of which side is compressed, radial or ulnar. So a positive test is if it does not fill within the 5 seconds.